So let's talk about managing DME. Now that we've talked about the progression to DME, that there are some things we can wiggle in the terms of management of patients to prevent their getting there quickly, but now we've got DME. Who are the members of the multidisciplinary team for patients with diabetes and their eye diseases? Who's on that team? Is it just ophthalmologists, or is there a larger, more all-inclusive group?
It's a large group. So it would be frontline would be a general ophthalmologist or optometrist. They would be the person at a lens crafter or even their own shop that would be basically screening eye disease at that point.
So wait, you just said optometrist.
Optometrist. So an optometrist is a person who goes through 4 years of optometry school and not through medical school. The ophthalmologists go through 4 years of medical school plus internship and residency and potentially a fellowship as well.
Okay, well, my sense is the optometrists come into contact with people far more broadly than ophthalmologists.
There's far more of them than there are any of us.
There's more lens crafters.
Yeah, absolutely.
You know, whenever you go to get glasses.
And more general ophthalmologists than retina subspecialists.
And I want to get into that too, because if you're dealing with DME, which is a retinal issue, right? Are the general ophthalmologists okay, or do you really need a specialist, a retina specialist, to deal with this?
Well, being a retina specialist, I'm obviously going to say I think you need a retina specialist. But you know, the thing is when you think about what we take care of as retina specialists, 90% of the time it's the basic three things: macular degeneration, vein occlusions, and diabetic retinopathy. So we do it over and over and over. We're not managing glaucoma, followed by cataracts, followed by diabetic retinopathy.
You're not doing LASIK?
We're not doing LASIK surgery or anything. The big thing is that we do it over and over. And we have the ability to use all of the different medications, the lasers, the latest technologies to take care of these patients.
But when is a specialist absolutely needed? I think it's fair to say that someone with more experience in a particular disease process is always going to be more experienced with that disease process. It's tautologic. But does everybody need that expertise?
Well, so I think that the best way to put this is that for the general routine eye care issues and for the early patient who's getting screened and evaluated, the general ophthalmologist suits everything. And in fact, many of them have been trained to do lasers. Lasers were a general standard of care for many people, and they might actually, in some areas, do some early treatments for diabetic retinopathy and diabetic macular edema. But when it comes to more severe patients, patients who need surgery, potentially patients who don't respond to treatments, they refer those patients to retina specialists like John.
How do you know when to do that? Where's the trigger point?
Yeah, so I personally think that when you see someone who has center-involved diabetic macular edema, and we can see this both clinically and with some of our imaging diagnostics, those patients really do better with retina specialists.
Okay.
One of the problems with general ophthalmology treating these patients is in many instances, they get the order. They get the treatments out of order. So they may say, you know what, I'm going to laser this first. And we know from some of our recent studies that those patients who receive early laser may not do as well as those patients who receive anti-VEGF therapy.
And you know that, and some other practitioners may not know that by virtue of the fact that's your area of expertise. That being said, if we take a look at the map of the United States, it's sort of like those AT&T and Verizon maps, the little red dots are everywhere. Optometrists, there's a lot of red dots. Ophthalmologists, there are fewer red dots. Retina specialists, even fewer red dots. And my guess, without having the data in front of me, but you might know, is that there's going to be an access issue for a fair percentage of the American population. They're going to be 50 miles, 100 miles, 200 miles from a retina specialist. How do you manage that?
So we do have that problem in certain areas, and in those areas, the retina specialists have partnered with the general ophthalmologist to educate them on how to treat the patients. There's correspondence with sending pictures or images of the scans and saying, when do I treat this patient?
I was going to ask about that. Could you just send the scans real-time telemedicine on the web?
Absolutely, you can. You can de-identify them and send them via text message to your retina specialist and say, when should I treat this patient? And so that's really kind of critical for those patients. In Kentucky, especially Eastern Kentucky, where we take care of patients, we go to see those patients. So we'll travel 2 to 3 hours.
You travel to them?
We travel to them. They have access issues, so we have to go to them.
Retina has become a regional practice nowadays. You know, the old days used to be that you had one office and you build, you know, like the house that Babe built, you all come there, right? And that doesn't work anymore in our specialty. We have many people that have 5, 6, 7 offices, sometimes take planes to get to where they need to go in order to take care of patients. And that's pretty much a commonality in our field now.
I must confess, just for a moment, I'm taken aback. I'm flabbergasted. Pleasantly so. You go out to where the need is.
Yeah. And similarly, of course, we're in a densely populated area, that being New Jersey, and lots of medical subspecialists. And that said, in the area of retina, we have seen this proliferation, pun intended, of retina groups having multiple offices, so going to where the persons are rather than somebody having to travel 25 miles, which in New Jersey might take an hour and a half. So having those, those satellite offices and being available a couple of days a week in a certain office or one day a week.
And I think the biggest problem is we take care of the second most geriatric practice other than geriatrics at this point. I mean, our patients are old, and they're not traveling necessarily to get to us. And so we have to be where they can be, and they can get to us conveniently.
I mean, on occasion, I must tell you, I do anesthesia in the Eye Institute. And as a group, all the pre-ops I see, that is the oldest slice of America you're going to see anywhere. The average age, it seems to me, is over 70, and the comorbidities are huge, and they're all hypertensive, and a fair number are diabetic, and they're all in for some therapy. But I'm stuck on this, that you travel, that you have an office out somewhere else where you can.
We have 11 offices.
That's wonderful.
And 60% of our patients in our practice come from satellites.
And it occurs to me this won't happen without you guys, without some kind of reimbursement scheme that says, yeah, this is a good idea, we're going to pay for that.
Well, we don't get down to the level of, so when the subspecialist, the retina specialist versus the general ophthalmologist, so we're really relying on our clinicians to make those decisions.
Okay.
We're not being proscriptive. We talk about the primary care physicians as having that comprehensive role, or the comprehensivist. That comprehensivist will then send patients to a general ophthalmologist. They may go directly to a retina subspecialist for certain select patients because they know they've got retina disease. Or they may rely on the general ophthalmologist to make that triage decision, that in the eyeball triage decision, and we really don't stand in the way of that. Again, we're looking for overall outcomes for patients with diabetes. Eye-related disease and diabetes is included in that.
You know, we haven't even mentioned, we've talked about optometrists, ophthalmologists, retina specialists. We haven't heard the name, the word, diabetes educator yet. I mean, that's another tier, another level of potential interface with the system. Where does that come in, and how is that reimbursed?
Well, I've actually spoken at the AAD meeting a couple times in the past few years, and it's an amazing group of people, of nurse practitioners, nurses who are diabetologists. They focus on nutritional education around the diabetic patient, and care organizers. And so this group really is the backbone and the coordinating group of that entire population. I mean, the primary care physician is one gatekeeper, but it comes more and more, I think, in managed care situations. Especially these people are the people that are helping to run their overall subspecialty care in their lives.
Yeah, we really emphasize team-based care. So some of our practices have a full or part-time diabetes educator. Some of the nurses that we help to pay for, we call population care coordinators, will then get some training, sometimes provided by pharmaceutical companies, on motivational interviewing, teach back, nutrition for diabetic persons. So there is a lot of focus on recognizing that the physician, she may not be the best person for certain aspects of the education and the motivation of patients. So diabetes educators, nurses that are trained as diabetes educators is very much a part of it. And then again, this notion of team-based care.
And you're paying for diabetes educators?
We don't routinely pay for diabetes educators. Again, we pay certain value-based payments, which are called care coordination and then outcomes-based payment.
How do they get paid? Who pays them?
Well, so the care coordination payment, some of that is going toward those persons who don't submit a CPT for the services they're providing. So there is enhanced compensation to reflect the fact that a high-performing practice may well have a part-time diabetes educator or have one of the nurses who is, in effect, trained as a diabetes educator. Sometimes we do actually see some of the pharmaceutical companies that will provide diabetes educators as an adjunct as well.
But let me see if I understand what you're saying. You're not paying them directly. They're not submitting a CPT code to you. So what you're doing is you're enhancing the payment to somebody who is, and hoping that flows through to the diabetes educator. Is that fair?
Well, again, it's not hoping that it flows through. It's that we're advancing team-based care. Diabetes education is a part of that. We could certainly debate who is the best person to provide that education. Is a RN without a formal designation as a diabetes educator able to do that as well. That's debatable.
Okay.
If he or she then obtains that certification as a certified diabetes educator, that would indicate a certain level of proficiency that is associated with that designation.